Good afternoon. Let's look at infectious mono. Again, I'm going to set it up as Butera does in your text, and we'll cover these important components, and I'll extract the data that you need to know. I do want to address the photograph on the left of the screen. I want you to look at the white exudate on tonsils. Those tonsils are about a +3. There's a lot of injection of the uvula and of the anterior and posterior oropharynx. This is a child with infectious mononucleosis. The definition of IM, or infectious mononucleosis, is an acute, self-limited, generally benign illness that occurs in children and adults after a primary infection with Epstein-Barr virus, cytomegalovirus, and other infectious agents. You know, we typically just think about Epstein-Barr virus because it's what we see most commonly, but it can be caused by other infections and other pathology. We are identifying infectious mono caused by Epstein-Barr virus through consideration of a triad of symptoms and findings: fever, pharyngitis, and lymphadenopathy. Epidemiologically, Epstein-Barr virus is most often diagnosed in adolescents and young adults between the ages of 15 and 19. Very high percentage from college or military because of the communal living. Less than 10% of children develop infectious mono after Epstein-Barr virus, but greater than 78% of adolescents develop infectious mono after Epstein-Barr virus. And it's relatively uncommon in adults. We don't really fully understand the epidemiology of this. So the pathogenesis, again, is that infectious mononucleosis can be caused by a variety of infections. It's also associated with some neoplasms. Transmission occurs via exposures to oropharyngeal secretions. The Epstein-Barr virus has relatively fragile DNA, herpes virus that cannot survive long outside the host. The virus actually infects the oral epithelial cells and spreads to the B lymphocytes, then circulates into the reticuloendothelial system. Incubation period is usually 4 to 8 weeks. So clinically, our patients present with the classic fever, pharyngitis, and lymphadenopathy. Typical adolescent is seen with sore throat, fever, lymph nodes that are tender, tonsillar enlargement, pharyngeal inflammation, and sometimes transient palatal petechiae is seen too. Pharyngitis is diffuse with exudates. Just look back at that first picture that I showed you. Adenopathy of both the anterior and posterior cervical nodes may be diffuse. Temperatures may be as high as 104. Symptoms that persist after this acute phase is malaise, anorexia, and fatigue. Symptoms typically peak in 7 days and are less pronounced within 1 to 3 weeks. But however, fatigue has been reported for months after having the virus. And then splenic enlargement is found in about 40 to 100%, and it can be confirmed via ultrasound. And we usually have to do serial ultrasounds. The physical exam required to considerations are the patient may or may not appear sick. The classic triad, as I told you before, with the fever, pharyngitis, and the adenopathy should raise suspicion to infectious mononucleosis. You need to assess the anterior and posterior cervical nodes because you'll find that generally they are swollen. Sometimes they can have nodes in the inguinal area, also the axilla, but these anterior posterior cervical nodes are definitely swollen. Typically, the abdominal exam needs to be included for assessing for splenomegaly and hepatomegaly, so that enlarged spleen and liver. And rash and jaundice may be associated with Epstein-Barr virus, infectious mononucleosis, especially in the elderly. So that's a nuance for you to remember. Diagnostically, CBC with the differential, we'll see absolute lymphocyte is abnormal, and that's indicative of IM. Serologically, we test for heterophil antibodies, and they're positive in about 85% of these cases. If negative test, but such a clinical suspicion, go ahead and retest in 7 to 10 days if symptoms persist. A positive test may remain positive for up to 1 year. And I gave you some testing parameters. We usually look at the VCA, the IgG, IgM antigen testing. You might want to consider a throat culture because 3 to 30% also have a secondary streptococcal pharyngitis, and you don't want to miss that. And liver function tests are often elevated in 80 to 90% of the persons with infectious mononucleosis. Management. Epstein-Barr virus infectious mono treatment is primarily supportive. Hydration, non-steroidals, throat lozenges, gargling with 2% solution. We want to avoid aspirin because of that correlation with Reye syndrome. Bed rest during the acute phase. And then a person with splenomegaly should avoid strenuous exercise for 3 to 4 weeks or until resolution, especially contact sports. You actually have to confirm resolution through ultrasound. Most people recover in 2 to 4 weeks. Referrals, please be aware of the complications of elderly patients, and also that another complication is that 23% rate of peritonsillar abscess, and you know, that clue and cue comes from that unilateral huge tonsil, and it can be obstructive and quite serious. They often have to be IND'd by a specialist. Patient education and health promotion includes education about the nature of the illness and the prognosis, the transmission of it via oropharyngeal secretions, and really avoiding that, allow adequate rest, and we have to educate about possible complications. Thank you.